Hello, and welcome to the Chest Journal podcast, where each month we host a discussion with the authors of important articles from the current issue of the journal, adding context and commentary to the challenges facing clinicians in the fields of pulmonary, critical care, and sleep medicine. To introduce today's topic, here's your host, Dr. Matt Siuba.
Welcome to this month's edition of the Chest Journal podcast. My name is Matt Siuba. I'm a medical intensivist at the Cleveland Clinic in Cleveland, Ohio. Today, I have the distinct pleasure to discuss a really interesting article that will be in this month's edition of the journal. It's titled Diagnostic Yield of CT Imaging and Point-of-Care Ultrasound After In-Hospital Cardiac Arrest. I'm lucky to be joined by two of the authors of the paper, Luke Andrea and Patrick Coppler. Gentlemen, thank you both for being here. For the benefit of our audience, if you could just start by giving us a general introduction of who you are and where you work, and we'll start with Luke.
Hi, thank you for having us. So my name is Luke Andrea. I'm an intensivist at Montefiore Medical Center in the Bronx, where I work in a variety of intensive care units. I'm the Associate Director of Research for critical care there, where I work with a large multidisciplinary team on all types of research, from observational studies to clinical trials, but cardiac arrest research is definitely a core focus of our group. And that's the focus also of my personal research, which is mostly on what to do after a cardiac arrest occurs.
Fantastic. Pat?
I'm Pat Coppler. I'm a physician assistant and a PhD candidate in clinical and translational science over at the University of Pittsburgh. My clinical practice, I'm based in the Department of Emergency Medicine, and I'm also a TL1 predoctoral scholar. Clinically, I work on our cardiac arrest service at UPMC Presbyterian. The clinical work here is focused on early post-arrest resuscitation and care, neurological prognostication, and the neurocritical care for cardiac arrest patients once they're in the intensive care unit is generally my focus. My research end of things broadly, my research applies data science methods to better understand brain injury after cardiac arrest. But components of that work have also looked at processes of care for our cardiac arrest patients, including imaging, including what we're talking about here today.
Great. Thank you both. Yeah, it sounds kind of like we got the perfect author team to talk about this topic. Let's start to understand the topic before we get into the specifics of the paper. Luke, what did we know about the role of post-arrest imaging prior to your study?
Yeah, so thanks. That's great. A lot of what we knew about imaging after cardiac arrest comes from the out-of-hospital cardiac arrest population. And we knew from out-of-hospital cardiac arrest that early CT scans were very good at diagnosing the cause of arrest, complications from the arrest and the resuscitation, things like rib fractures or trauma to different organs. And although more work is probably still needed, there is even some signal that doing these CT scans early after an out-of-hospital cardiac arrest might improve outcomes for patients. A lot of this work is from Pat's group at UPMC. There's a lot of work out of University of Washington from people like Nick Johnson's group and many others. But one thing is that, as is often the case with cardiac arrest research, there's much less data on what to do after an in-hospital cardiac arrest. They're much less comprehensively studied. So the question sort of became for us, can you apply all of this great data from the out-of-hospital cardiac arrest to cardiac arrest that occurs in the hospital? A lot of times the answer to that question is probably you cannot do that. Out-of-hospital cardiac arrest, I usually think of a healthy person who's then found on the ground at home or found on the ground in the street. There's usually something very acute that brought that patient from fully functioning out of the hospital to all of a sudden now their heart is stopped. And that kind of patient, it makes sense that they'd benefit from doing a full body scan in order to find out what that acute injury was. For a patient in hospital, however, a patient that I would think about would be somebody who's there with progressive respiratory failure from pneumonia. They've already been worked up. Maybe they've already even been imaged. They've been intubated. Now they're on vasopressors. Now they're going into renal failure, and then they have a cardiac arrest. So that patient, you would think that you might have a better grasp on sort of what is going on there and what caused the cardiac arrest. So the question then becomes, will getting a scan in that patient tell you something that you don't already know? Or is it just an unnecessary risk to move that patient over to a CT scanner to try and get more information?
Yeah, it's a really good point. And as you were talking about that, I started to think about it. When I first thought about that, I was thinking about it from the perspective that you just gave, and also the perspective in the introduction of the paper. But what's really interesting here is like it's almost a chance to sort of double check whether the diagnosis that we were working with in the first place before the arrest was right, or something new happened, or whether it's a sequela. What the things we find are sequela of the arrest. So really super interesting. Pat, can you talk to us more about the inspiration for the study question and how you all developed this study?
Yeah, sure. For us, I can give you, as Luke pointed out, we've had some prior studies in this space, and I can tell you a little bit more about kind of the impetus for those. First, our clinical experience when we started to look at our out-of-hospital cardiac arrest imaging practices, it kind of came from a lot of anecdotes together. One colleague would tell us about a liver laceration they found on the abdomen pelvis CT. I would say something about an occult big pneumothorax that was just anterior on the chest X-ray that we found, or it becomes a little more clear with history that the patient had a fall where it wasn't as obvious, and on cervical spine imaging you find a fracture. One of our colleagues, Dr. Jonathan Tam, actually has his residency research project, reviewed all of our out-of-hospital cardiac arrest patients for several years, and found similar things to what Luke was talking about. CT scan often picks up the cause of the cardiac arrest. It often picks up complications related to the resuscitation itself. And our gestalt is those things inform treatment decision making. And around the same time, one of my other partners, Dr. Cecilia Rattay, was thinking specifically around our practice in obtaining brain CTs early, specifically in the first number of hours after resuscitation from in-hospital cardiac arrest. That focus was kind of on a prognostication and capture of neurological causes of arrest, as in how often do we find something that's really clinically informative on those CT scans. And she found really in the first few hours, severe edema was really uncommon, and intracranial hemorrhages were very rare compared to the data that we have from the out-of-hospital cardiac arrest patients. So we looked at other imaging a little bit in that paper just to say yes or no. They went off not just to get a CT of their brain, but also got other imaging. But really, we had some similar thoughts of kind of aligning what our out-of-hospital cardiac arrest clinical experience was. And that, for our group, got us thinking about really the evidence that informs the guidelines. For example, the American Heart Association recommends obtaining imaging and echocardiography or point-of-care ultrasound. But the evidence comes from the out-of-hospital realm. And as Luke said, this really is a vastly different population. Just to add, in the emergency department, early on in the resuscitation, maybe I have a name, maybe I have an age, maybe I have some arrest characteristics, and if they got shocked, but often it's kind of third-hand information. I really don't have a lot to work with. So it really is an open question for our in-hospital cardiac arrest, as Luke said, where we know a fair bit more about these people. We have, care teams have been established and workup is ongoing. What is kind of the place for imaging in those folks?
Excellent. Thanks for that. That was very nice background tying into the what we're actually looking at in this study. Now that we've kind of understand the background, Luke, what's the basic overview of the specifics of the design of the study?
Yeah. So, my research mentors, they'll tell me that, whenever you're designing a study, the most important thing to think about is getting the question right, and then sort of the methods will flow from there. So, I think that, again, we've already talked about the question a little bit, but, our question really is, when you're in this early phase of cardiac arrest, you're stabilizing and diagnosing a patient who's been in the hospital after their cardiac arrest. This is before you're starting to prognosticate. We wanted to know, what are the practice patterns for what people are doing as far as imaging for those patients? What are they finding? And then how, if at all, is this changing management decisions in the early phase after cardiac arrest? So we did this as a retrospective observational study. It was 3 hospitals at the Montefiore system and 1 from UPMC. All of the patients the majority of patients came from around 2023, but the date range extend a little bit inside and outside of 2023. But basically, this is a post-COVID population, so we wanted to get a population that it was not so much influenced by changes in management during the time of the COVID pandemic. One thing I want to say about our screening for these cardiac arrests is that both of our groups have very comprehensive ability to screen for in-hospital cardiac arrest. We weren't relying on ICD-10 codes to identify these patients retrospectively. Both of our groups have very detailed quality improvement tracking that is able to identify every cardiac arrest that happens within the hospital. And we were able to identify cardiac arrests through that, which I think was a really big benefit to the study. We looked at all adults that had a cardiac arrest in the hospital and achieved ROSC. For the cohort of CT patients, we did condition on patients who survived at least 24 hours. And this kind of goes back to the question that we were asking. We're interested in patients who were resuscitated and being worked up at that point. By conditioning on patients who survived at least 24 hours, we're excluding some patients who would have been so severely ill that they died shortly after ROSC, or patients that were transitioned to comfort measures only immediately after ROSC. Those patients would have been excluded. For the POCUS cohort, because we thought that POCUS could be applied immediately, we did not exclude any patients from that cohort. And then our teams went into the charts, looked at the radiology reports, looked at what happened to these patients, a lot of narrative review to get information on the CT imaging and the POCUS imaging. Our two main outcomes were diagnostic yield, so were there any new findings identified, and then whether or not there was a change in management that happened because of the imaging. For the statistics, it was really all just descriptive. We didn't make any comparisons or do any adjusted analyses.
Great, thanks. It looks like a very pragmatic look at a problem that we all face. So very, very helpful. Pat, what are your key takeaways from this study?
Yeah, here I think we found that imaging after in-hospital cardiac arrest was common in our hospitals. Around half of the eligible patients in the CT cohort underwent imaging, cross-sectional imaging, and roughly 3/4 of patients had a point-of-care ultrasound. And while our inclusion criteria was to consider imaging done within 48 hours, most of these patients were going off pretty quickly to CT scan after ROSC. They had a CT median time within 6 hours. Ultrasound was around 2 hours. And mirroring what we and others have shown in the out-of-hospital cardiac arrest literature, imaging identifies important things across body regions. And these are things that albeit they're often rare, they're things that you don't want to miss. So in cross-sectional imaging, anoxic brain injury was identified in about 1 in 10 head scans. On chest CTs, you find pulmonary opacities and rib fractures in lots of people, but you also identify pneumothoraces and pulmonary embolism. On abdomen pelvis imaging, you can find ischemic colitis and bleeding in some patients, along with for point-of-care ultrasound, there's some other actionable findings that you find with those scans. RV and LV dysfunction, deep vein thromboses. So across both of these imaging modalities, imaging identified something that was new. That finding often resulted in some, say, procedure, medication change, or a new subspecialty consultation for the patient. And lastly, the big clinical question that I think a lot of us that work around the ICU or in the ICU think about is, what's the safety profile of going off and getting cross-sectional imaging and upending the patient from the ICU? We found that just one patient had a complication during their imaging. So overall, it seemed that, which is kind of consistent with other literature that looks at going off for trips in ICU patients.
Yeah, I thought that fact was very interesting. We often spend a lot of time worrying about if the patient is safe enough to transport. And in this cohort, at least, we saw that only one episode out of all the patients included is fairly impressive. Luke, when you start to think about these results, what kind of, hypothesis generating information comes out of this study for you?
Yeah, I mean, I think that there's a couple questions still here. I think that we clearly were able to show and found that you do get a lot of new findings, and that a lot of these findings change the management decisions that are made. I think that potentially a pessimist looking at this paper, might look at some of the results and say, oh well, a lot of the new findings that they found were things that weren't so immediately life-threatening or deadly conditions. They found a lot of new pulmonary infiltrates. Almost 60% of the patients had some new pulmonary infiltrate identified. And things like pneumothorax or pulmonary embolism were a little less common. I think pneumothorax, we had about 5%, pulmonary embolism about 8%. But even identifying, newly identifying some sort of pulmonary infiltrate, like an aspiration event, I think it's still very important information to have. It changes how I manage the vent. It might change how I manage a patient's volume status, and it does change some of the therapeutics and diagnoses, diagnostics that I'm implementing for this patient. So I do think that it's still very important information, but probably identifying larger cohorts to really get a sense of the rate of these immediately life-threatening conditions would be one next step. I do think that for me, and we talked about it a little bit, but one interesting thing was that it was a very low complication rate. One of my initial hypotheses going into this was that providers would be much less ready to send patients who had a very severe cardiopulmonary insufficiency. So, a patient on high vent settings or a patient on lots of vasopressors, they'd be much more hesitant to send a patient like that to the CT scanner. So Pat and I were able to pull SOFA scores for these patients in the time immediately post-arrest to get a sense of how sick these patients were from a cardiopulmonary standpoint. And we really didn't see any signal that the patients who did not go to CT scan were more sick from a cardiopulmonary standpoint. So I really do think that there is some pretty good data there, at least to show that there wasn't a lot of complications, and that even patients who are on high vent settings or high vasopressors, that you can still make the decision to bring them down if you think that it's worthwhile. One of the other interesting findings, I know Pat talked about it a little bit. I was very surprised by the findings from our POCUS study, where we saw a lot of DVTs and a lot of arterial thromboses. About 10% of the patients who got an ultrasound of the vessels had some sort of thrombosis, either in the vein or artery. And that kind of changes how I look at imaging in from the standpoint of, if I'm going to do this imaging, either a CT scan or a POCUS, I really do want to make sure that I'm not skipping any organ systems. I think that probably similar to what they've done in the out-of-hospital cardiac arrest, where they protocolize these images, probably should be looked at for the in-hospital cardiac arrest side, where, if you're going to get a CT scan or if you're going to do an ultrasound, just do the entire body. Don't just do your heart and lung ultrasound. Make sure you're doing an ultrasound of the abdomen. Make sure you're doing an ultrasound of the legs to look at the vessels. And if you're going to send somebody down for a CT chest, I think that it's worthwhile to just do the head-to-toe scan like it mentions in the new AHA guidelines.
Yeah, thank you. That was pretty insightful stuff. One thing that I was thinking of as you're talking through that is, we have all these new findings, and as you rightly said, some of them are probably not directly related to the etiology of the arrest, but they certainly will change how they're disease modifying factors, and they'll change how you treat the patient subsequently. So I think it's still very useful. Now, Pat, what do you think about sort of words of caution for the readers and interpretation of these results? Specifically thinking about limitations to the study and things of that nature.
Yeah, certainly there are limitations. This is a retrospective observational study, which has all the well-known limitations that go along with that study design. But there are a few things for the clinical audience worth mentioning specifically. We were intentionally broad with how we defined a change in management, but certainly not all management changes are the same. say, of severity or time dependence. So a neurology consultation because concerning signs for anoxic brain injury were found on a CT scan is very different than, say, finding the occult pneumothorax and putting a chest tube in, or the pericardial tamponade and putting a drain in. This is a multi-center study. Most of the out-of-hospital cardiac arrest literature on this topic comes from single-center studies. So 4 sites is a good multi-center cohort, but still, none of our sites had a specific protocol for post-arrest imaging. So we're really reporting findings and diagnostic yield on practice patterns in these 4 specific places, and whether that's the same elsewhere needs further study. And I think the biggest thing is that how the data were generated, it was basically confounding by indication. The clinical team at the bedside ordered these tests, and we were able to abstract the data. So clearly there could be patients where things weren't really entirely clear, where the clinical status is getting worse, or the kind of improvement with the initial suspected etiology, the patient's not responding as you think they would be. They would probably more likely to go off and get cross-sectional imaging or get a point-of-care ultrasound, which likely, inflates the findings that we're reporting. All that said, I think our overall message that we've been discussing still holds.
Absolutely. Thank you. Luke, now that, let's say you're a clinician that reads this paper, what do you think, how do you think this should change their thinking about post-arrest imaging in the future, understanding that there's limitations to this data, but we still learn something from it?
Yeah, I think as far as, practice goes, there's a lot of people that are a lot smarter than me that put a lot of time and thought into the AHA guidelines. So the new 2025 guidelines, they give a 2B recommendation that you should consider a CT scan, full body CT scan, and that you should consider POCUS for all patients where you get ROSC. In their guidelines, they did write a caveat that there's not any really good evidence for the in-hospital cardiac arrest population. But, since we've published this, I think that now we do have some evidence for the in-hospital cardiac arrest population, and I think it supports the practice. Same sort of range of findings as the out-of-hospital population, and same sort of rates of changing management as the out-of-hospital population. So I think that, with this new evidence, I think it supports that you should consider CT and POCUS for patients who get ROSC from an in-hospital cardiac arrest. I think that, the most important thing for managing any patient after a cardiac arrest is to just have a protocol. Make sure that you're doing the same sort of thing for all patients. If that includes or doesn't include considering full body CT and POCUS, if you think that your population doesn't really match the types of populations that have been published on previously, or if you do think that it's a good idea to include a recommendation like that in your protocol, I just think that it's important to have a protocol, look through the guidelines, make sure that your protocol is guideline concordant. And then I think that if you do want to put some sort of consideration for imaging in your protocol, I think that making sure that that imaging is comprehensive is one of the big takeaways that I would say, rather than just sending everybody down for a head CT to rule out intracranial catastrophe. If you're going to move them to a CT scanner after an in-hospital cardiac arrest, just scan their whole body is what I would say.
Excellent. Any final thoughts from either of you? I'll start with you, Pat.
Yeah, first thing I'd say is, from a research standpoint, this project was a really nice way to collaborate with our colleagues over in Montefiore Medical Center about a common problem that we really all deal with every day. And even a descriptive piece is able to inform practice whenever guidelines all note that our data are coming from a different population to inform a very different problem in the hospital. So this was a really nice project for us to, even in a descriptive piece, to help inform our practice. I think that our overall message is not that every single patient resuscitated from in-hospital cardiac arrest should just go off and get rushed to image. the decision to image is still clinical and context dependent, and things we simply couldn't recreate in a retrospective look at the data. I think we've shown that when imaging is obtained, it has reasonable diagnostic yield and leads to some changes in the patient management, probably for the better. I think that that's a little distinct from saying that it should just be done in every patient or really routinely. And the other point, I think, is a little under-discussed in the broader literature on this topic of imaging after cardiac arrest. I think the value of imaging is finding things, but also excluding pathology. Understandably, most of the other studies in this space focus on the N and percent of things that you found. But for the clinician at the bedside, these patients have whole body ischemia reperfusion injury. Their resuscitation meds wear off after a bit. They get sicker in the first few hours after resuscitation. So I still see that there's value, even if, say, not major things were identified on imaging, that, you've rolled out a pulmonary embolism or you've rolled out any kind of major intra-abdominal hemorrhage, I think is still of value. I think that may sound like those 2 points are kind of at odds with each other. But I think clinicians can still be thoughtful about imaging selection upfront and recognize that the value is not just in identifying positive findings. So I'd say if, imaging isn't pursued, then you can still think about it if the patient's trajectory isn't reassuring, and reconsider it if things just aren't adding up.
Yeah, I like what Pat said there. Pat and I have talked about this too, where a hypothetical patient that you've resuscitated, that you POCUS and you see this RV dysfunction. Are you gonna think that maybe a PE is the cause of the cardiac arrest there? I don't know. I mean, it's worthwhile to do the scan as a rule out, I think, in that case. Like Pat's saying, that it has some negative diagnostic value there as well. And indeed, we showed a lot of patients had RV dysfunction immediately after cardiac arrest. So.
Yeah, super interesting. Gentlemen, thank you so much for being here today. This is a really interesting study and a really nuanced discussion about it. So thanks to both the authors, Luke, Andrea, and Patrick Coppler, for being here to discuss this article called Diagnostic Yield of CT Imaging and Point-of-Care Ultrasound After In-Hospital Cardiac Arrest. We'll see you next time.